Hello, everyone. Today, our guest is a tenured faculty in the sociology department at Franklin and Marshall College. She teaches in public health, public policy, Africana studies, women, genders, and sexuality studies. um, she has a joint PhD in sociology and public policy and a master's in public policy at Brandeis University. She also has a master's degree in women's studies at the University of Sussex. Today, welcome Dr. Ashley Rondini.
Hi there.
Okay, the recording's starting, but we could cut that part.
Is my hair crazy?
No,
You would
it's
tell me,
good.
right? Okay.
Okay. Hold on. Just wait.
Bachi's scratching his ear.
Aww, baby.
Okay.
Okay, so
Hi.
why did you decide to become a professor and what sparked your interest in sociology?
So I think both of those things are attributed to a really important mentor that I had in my life. When I was an undergrad at Clark University, first of all, when I arrived there, I didn't know what sociology was. I think it's probably still the case that a lot of high schools don't have sociology, and mine definitely didn't. So I hadn't heard of it before I got to Clark University, and in my first semester, I took a sociology class with Professor Shelley Tenenbaum. Let's give a shout out to her. And when I took her class, it was like a whole new way of thinking about the world opened up to me. I actually went to Clark thinking that I wanted to be a psychology major, and Clark is a really good school for psychology, so that was one of the reasons I went there. And within one semester, I knew that I wanted to take every sociology class that I possibly could, and more specifically, every sociology class with Shelley Tenenbaum that I possibly could, because I felt like it helped give me language to the questions that I had had about the world for a really long time that I didn't necessarily know how to ask until I started reading the things that were assigned for that class. And so I learned that sociology was a way of thinking critically about power and thinking critically about systems and social institutions and how history frames our experiences as individuals and as groups of people in ways that I had wondered about before, like the way that we group ourselves by race and by gender and by ethnicity and by different things that separate us from each other, but also by different things that connect us to each other. So as I got deeper and deeper into sociology, it opened up other lines of questioning for me about identity and about how we are connected to each other in ways that make us responsible for each other in the world. And I really couldn't have had a more powerful experience, I think, than I did as her mentee. So it taught me a couple different things. One was the importance of thinking about the world in a critical way, in a sociological way. And then a bigger life lesson was how important it was to have mentors along the way who could believe in you and see things in you that you didn't know about yourself before. So I didn't know that I had the potential to be a sociologist because I didn't even know what it was. And certainly no one in my family knew what sociology was. But I think what led me to want to work with college students now as a professor, but earlier on in my career in student affairs and in more kind of mentoring roles, was this idea, and literally I got this off an internet meme, the idea of wanting to be the person that you needed when you were younger, because Shelley Tenenbaum was the person that I needed when I was a college student because of the ways that she looked out for me, not just as a student, but as a whole person, and helped me find my path. And being in a position to help students do that, help them figure out the questions they want to ask about the world and what's important to them, but to also just provide support as they figure out those questions for themselves. I feel like when I work with, especially first-year students and students that are trying to figure out what they want their education to mean to them, I often think of her and all the ways that she helped me do that.
Okay. Okay. So I was muted, but
and she still teaches at Clark University, so she's still
shout out.
She's still changing lives.
Period.
like, wait, Clark, you know, the Superman Clark?
Oh,
Clark Kent.
it's all
Yeah.
connected.
Yes, she's my very own Shiro and superhero.
Okay, so what does your job do? Like, what do you do in your daily day in the job?
Yeah, so it's a couple of different things. So when you think of a professor, you think of a teacher, right? You think
Yeah.
of somebody in front of a classroom. And that's a big part of what I do, is to teach classes. But that also means designing the classes. So coming up with thinking about how we're going to structure a deep dive into a particular topic, and what kinds of assignments are going to be designed for students to explore that topic, but not just the research that's been done about it, but what kind of research methods I want them to be considering, what kind of theories I want them to be applying to the topic, and then how I want them to be able to take the information they've learned about that topic and those research methods and then apply them more broadly to other topics, or apply those research methods to the way that they think about other areas of inquiry in the world that they might be curious about. So that's, and in the teaching piece, sometimes that means a traditional class where I stand in front and help facilitate discussion. Oh, sorry.
okay.
Help facilitate discussion. I don't do a lot of straight lecturing because I like to do a lot of discussion-based learning. So my approach to pedagogy is to get students talking to each other more often than not. So I provide information about the readings, and then I ask a lot of questions where I want them to talk back to me and to each other. But apart from that, I've also worked with a lot of students on their own independent research. I've had a lot of student research assistants for some of my research, and I've had students co-author peer-reviewed papers with me. And then apart from the specific pedagogical or research part of, the teaching part of it, I do research of my own as well. So I do research and publishing within academia for the topics that I have expertise and interest in. And for me, I consider myself an applied sociologist, meaning that I don't just do research that's published in academic journals, but I do public-facing research. So I apply my sociological expertise to public issues or current events. I write op-eds that are published in newspapers and magazines that give kind of an academic understanding to a broader audience to help people understand things at a deeper level that they might be hearing about in the news or watching on TV. And I also work on things that might be able to influence policy in different ways. So, for example, the work that I've done as a medical sociologist, which I think we're going to talk about in a little bit, has had some impact on medical practice. But I'm also going into, for this year, I've been named a Public Outreach Policy Fellow for the American Sociological Association, which is very exciting. And I'm going to be working with the Brookings Institute on some public-facing policy issues related to racial equity as well.
How is racism interlinked with medical history, and why do we have to look at it with a critical eye?
That's a great question. I'm so glad that you asked. So as a medical sociologist and as a sociologist who focuses a great deal on structural inequalities, and in particular the structural inequalities that are related to the social construction of race, I've had the privilege of working very closely with Dr. Rachel Kowalski at Weill Cornell Medical Center over the last decade or so, in focusing our collaborative efforts towards clinical practice guidelines in medicine. So I'll say that first, and then I'll go on to say that when we look at the history of medical knowledge, the history of medicine, one of the things that we have to be really mindful of is that medicine, like any other body of knowledge, is generated within a socio-historical context. So that means the people who are developing knowledge or developing research or developing science are never doing it in a vacuum of socio-political circumstances, right? So they're always situated in the context that they live in, which means they're not without bias. So when we go back and look at medical science that was conducted or that was developed or that was theorized during the antebellum period, or during periods of time where there was tremendously pervasive racist ideology throughout the society that the doctors who were developing that information were living in, we can't assume that they were immune to those ways of thinking, particularly if they were benefiting from those ways of thinking. So in recent years, there's been a lot more attention paid to the ways that doctors who were enslavers during the antebellum period were instrumental in forwarding and perpetuating biological ideas of racism in the interest of protecting slavery as an institution. So doctors who were buying and selling Black people to use their bodies in medical experimentation and in medical research in a way that completely dehumanized and exploited Black people's bodies benefited from other people believing that Black people couldn't feel pain, that Black bodies were fundamentally different from white bodies, And as a result of the things that they published and wrote during those periods of time, there are these long-standing mythologies within medical science that we're not totally free of to this day. And a lot of the unearthing of those biases has been revisited in recent years. There's been a bit of a reckoning that I think that we are still engaged in very deeply and still have a lot of work to do in. So Dr. Kowalski and myself have been working specifically on this piece of it that's focused on clinical practice guidelines in medicine. And what that refers to is basically the decision-making trees that physicians are expected to follow when they treat you. So when you go and see a doctor and you are presenting symptoms of something, some kind of illness or some kind of discomfort that you have, your doctor is assessing you as an individual, but is also drawing on the field of knowledge that they were trained in, right, in medical school, that sort of calculates different risk factors and calculates different signs and symptoms of things in accordance to what's considered best practice and existing knowledge. So it's sort of a, if the patient shows this, then do this kind of way of thinking, right? So certain symptoms at certain levels of severity merit certain tests. So you can pass a threshold of certain levels of severity, or having had a symptom for a certain period of time means that you get this test or that you get this treatment. But one of the things that we found is that sometimes medical practice guidelines that have outdated ideas about race embedded within them have different thresholds according to race for the same kinds of illness conditions. And that's really problematic, because what that means is that the guidelines that do that are often tied to pre-existing ideas that go way back to notions of Black bodies having different thresholds for pain, or different vulnerabilities to different illnesses that are not actually based in sound scientific reasoning, but that are based in the biases of the periods of time during which those theories were developed. So if we don't trace it all the way back to figure out where that came from, and we just take it as given because the existing science has cited previous science, has cited previous science, has cited previous science, we may not realize that we are replicating something that came from medical research as far back as slavery era research, that if we just looked at it now, if somebody was just producing it now, we would think, oh, that sounds completely unreasonable and racist. But if it's embedded deeply enough, we may not realize where it came from. So uncovering the past history of what we think of as knowledge, so that we're recognizing where the biases came from, so that we don't keep replicating them, becomes really important, so that we're not bringing those inequalities forward and continuing to reproduce them in the present.
Okay. Oh. Okay, so we know that you did a lot of research and you have a lot of published work. Which piece is your favorite?
It's really hard to pick a favorite, but since we are talking about the racism in clinical practice guidelines part, I will say that one of the most rewarding things that has happened with research, as somebody who wants to do applied work that really matters in the world, is related to a project that Dr. Kowalski and I did when we were able to publish an op-ed in the Journal of the American Medical Association back in 2020 about a specific clinical practice guideline that was for testing for urinary tract infection in infants. And I know that sounds very niche and very specific, but here's why it matters. Urinary tract infection, when they are untreated, can become very painful. And infants or babies can't speak, right? They can't tell you why they're hurting. But one of the main indicators of UTI is fever. And one of the most common reasons why people bring babies to the emergency room or to the doctor is if the baby has a fever, right? Yeah. So if a baby has a fever, really common reasons why the baby might have a fever: ear infection, throat infection, or urinary tract infection. Okay, so follow me on this. Okay. So all of those things are bacterial infections that could be treated with antibiotics, but you just have to know what you're treating, right? So the guideline that existed had a couple of different things that you had to assess before you, as a doctor, would put in an order for a urinary tract infection test. And the reason why they didn't do it more readily is it's an expensive test. Okay, so it's for a baby, you have to use a catheter, meaning a tube that goes inside the baby's urethra. Because for an adult, they would have you urinate in a cup. It's easier. For a baby, you can't do that. Yeah. Okay, so it's a little more involved.
Wait, they can't pee?
In a cup. You can't get a baby to stand up and pee in a cup.
You can do that.
So you catheterize a baby. So, okay. So stay with me. So here are some of the things that were equal across everybody that would indicate whether or not a urinary tract infection test should be ordered. One, have you already checked for ear infection? Makes sense. Have you already checked for throat infection? Makes sense. If you have, that's a point in favor of now it's time to check for UTI because you've already eliminated that would be one of the other two. How high is the fever? So is it, not just like 99, but is it, above 100? Okay, that makes sense.
Yeah.
How long has the baby had the fever? That makes sense. And then, is the baby non-black?
Huh?
Actually?
Okay. That's interesting.
And like, where would that be? Would that be like on their checklist or something? Like
That was part of the decision-making tree.
official? Like official medical guideline.
Official medical guideline.
Oh.
So the idea there would be that black and white babies had some sort of a difference in their vulnerability to UTIs, which doesn't make sense
Not
because
quite.
a UTI is a bacterial infection. It would just mean that bacteria entered the urethra differently.
Mind you.
Right.
Right.
And the other thing is that this was slightly different for boy babies and girl babies in the way that race was operationalized. So one was, is the baby white? And one was, is the baby non-black? Which is also an inconsistency if you think about this and the fact that race is not a binary variable, right? So let's say you had an Asian baby. Is the baby white? If the answer to that is no, and the baby is Asian, then that puts the baby in the non-white category. But is the baby non-black, then that puts the baby in the other category,
Yeah.
in the yes category, right? Because it's separated out differently. So we looked at that and thought, what is happening with this rule? There is no biological difference.
Basically, everybody was thinking very abstractly.
Yeah.
And they thought bacteria also segregated.
Yeah, it
is
makes
happening?
sense, right? But if you think about that from an implementation perspective, what that would mean is if you needed a certain amount of yeses to get to the threshold for getting the test, and if the baby is black and they couldn't get those yeses, that means they need more yeses on the other side. So assuming there's no ear infection or throat infection, that would mean that those babies would either need a higher fever or a fever for longer to qualify for the test. So what does that mean? That means the baby would need to be sicker before they'd be treated.
It's concepts.
Right? So in other words, under that guideline, indirectly, if you think about it deeply and critically enough, black babies would need to be sicker and have more severity of UTI before they could be treated for UTI. Do I think anybody who was following that guideline was trying to hurt black babies? Absolutely not. Do I think we needed to take a really close look at why it was being implemented that way?
Yeah.
So we tried to dig through what was happening with this rule. And what we found was a lot of the research that this was based on went back to some large-scale studies that were done in the 1980s. And we tried to look at how race was operationalized in these studies. And race was operationalized very inconsistently in the studies that this was based on. So first of all, in some of the studies, they made no mention of how they put people in racial categories. So we don't know if the researchers were just looking at people and deciding, or if the people were deciding themselves. There was often...
This is actually just straight BS. Like, I'm so sorry, but what is happening?
There was often no multiracial category.
Oh,
And there was often...
so you can only be one.
And there was often no category other than black or white.
Wow.
Wait, yeah,
no,
they're
I'm
so
not.
smart.
Wait,
Wait.
no, I'm not a thing. Like,
Yeah.
Okay, bye.
So by the time we sort of brought all of this forward and pointed out all of the methodological flaws in the foundational studies that the guideline was based on and were able to write about it, I think we made a pretty strong argument as to why it wasn't a methodologically sound aspect of the guideline to follow. And on top of the fact that following it could reproduce these inequalities that systematically disadvantaged black patients. And also know that if there are repeated untreated UTIs, ultimately that can cause kidney damage. And when we fast forward into adult life, guess what population disproportionately suffers from kidney illness, kidney disease?
African.
Yeah. Black populations. So there's a lot of layers to it, right? But it's really important to get at where these guidelines come from, and this is something we're really passionate about. So we published that in 2020. And ultimately, the American Academy of Pediatrics decided to retire the rule. And when they did, they cited our work.
Yay!
So that was really exciting. And there was a piece that was published by Joseph Wright, the president of the American Academy of Pediatrics, and colleagues, about moving away from racialized medicine, where they used our work as an example of what the problems with racialized medicine are and why it's problematic to be thinking about racialized medicine in those ways. Which is not to say, and I want to be clear about this, it doesn't mean we want to not pay attention to race, because there are a lot of social and structural implications of racism that have bearing on health. So it's not that we don't want to know about race, because there are indicators of racism that have an impact on health. But those aren't based in fundamental biological differences in bodies. And so we want to be careful to be thinking critically about that.
I'm honestly just like so surprised that no one had looked at it before.
Well, I
It's
think
just
one
like-
of the things to be aware of is we still haven't done that with all the rest of the clinical practice guidelines. So there are other ways that I think there are other folks that are trying to do that now. So there are folks that have cited our work to look at other guidelines. And we're really glad to have started to open that door for others to start to unpack. Because again, Dr. Kowalski is a pediatrician, so she was and she's an emergency room pediatrician. So she was very aware of this rule because she had seen a lot of young children in the ER who come in with fever. That's why it was very squarely on her radar. And she brought it to me as a sociologist to say, what do you think of this? And that opened up this dialogue between us with my expertise in sociology of race and her expertise in pediatrics. So we were able to kind of combine our superpowers, right? But there are other subspecialties that might be able to see similar or analogous issues with the guidelines for whatever they see the most. And we're hoping that they'll be able to kind of recognize those patterns.
Yeah.
Okay, our last question.
Sure.
So our last question is, what is one uncommonly heard piece of advice or lesson you have learned?
Yeah, I would say lean into the side quests. So this is when I talk to first year students or students who are just heading off for college, I think more often than not, young people feel like they do or they should have a clear idea of exactly what they're going to college for and exactly what they're going to do when they get there. And I think that socially there's this notion that you're supposed to know what you're going to major in before you even get to college. And I would strongly caution against young people being made to feel like they need to do that, because I think it sets you up to feel as though when you get to college, if you don't stick to that idea, you have failed somehow. But I honestly think that the best thing that you can do when you get to college is explore. I would not be on the path that I'm on now if I had stuck to the idea that I was going to be in psychology, because I didn't know sociology existed before I got to Clark. And I love what I do. But I also think the best thing you can get out of your education is a broader worldview. And you only get a broader worldview if you explore things you didn't know about before you got there. So exploring things you didn't know about before you got there means you have all these opportunities to find out other things that you may want to explore more deeply. And I think giving yourself permission to do that without setting yourself up to feel like if you find something you loved more than what you thought you were going to love, you're failing or somehow like not fulfilling your destiny. I don't think young people should be made to feel that way or should put that pressure on themselves. I think knowing that the earliest parts of your adult lives should be exciting because you don't know where you're going to end up is the best way to go about it. And maybe you will end up where you thought you were going to be, but it might be a curvier path to get there than you thought it was going to be. I think that's the best part of all of it.
And do you want to say what % of college students change their major?
I sure do. I like to talk to college students about this. I often will ask them to guess what percentage of college students do you think arrive at college thinking they know what they're going to major in, but somewhere along the line change their mind and end up majoring in something else. And that number is 80%.
Yeah.
So it's not just more than half, it's really the majority. So that's not a failure. That's a function of education, is it teaches you to see the world in more ways than you knew you were going to.
And I agree with that, because yesterday we did yoga with goats.
Oh yeah, we did yoga with goats
And
yesterday.
And it really opened my mind like, I don't think I'll do that in the future, but you know what? I experienced it, and I know that I won't do it in the future now.
But you did great.
Yeah.
And I'm so glad you did it.
You guys should see me and Zoe doing our yoga poses on top of each other with the goat on top of me.
You were so good at it. I was so proud of you.
Some may say that this is a side quest.
You're the side quest.
You're the side.
Embrace it. Lead into the side quest.
Yep.
Yep.
Exactly. Okay. Thank you.
Thank you, everyone. Zoe is obviously not in the center.
Zoe is the queen.
No, she's flopping off the center. But
You're the flop.